Hey future nurses, this is Mrs. D with ME Nursing Tutoring, and today we're going to be talking about tachyrhythms. Now, I know you guys are loving this content, so like, subscribe, and follow for more. Also, check us out on our website at www.nmetutoring.com. So, let's get started. Today, we're going to be talking about two commonly confused tachycardias, and they are completely opposite of each other, and that is ventricular tachycardia and supraventricular tachycardia. Now, I know the first question becomes, they are the same. They both have ventricular and they both have tachycardia. What's the difference? I'll explain. First things first, if you've ever taken medical terminology, you then know that there are prefixes and suffixes that are very important to bear in mind when we're talking about anything medical, okay? So in this case, supra means above. Why is that important? Because it means that it's not directly in the ventricles. Now, if you guys remember about the ventricles is the pumping part of the heart. So that's what is the part of the heart that is so important in terms of getting the blood out of the heart. So supra means above. And what's above the ventricles? If you thought atriums, you are correct. The atriums are on the top part of the heart and the ventricles are on the lower part of the heart. And the atriums are what collect blood to then push it down into the ventricles to then be pumped out of the heart. Okay, so atriums are the collecting part of our heart, whereas the ventricles are the pumping part of our heart. So now that we have supra taken care of, ventricular just means above ventricle. So it means essentially atriums. And then tachycardia, we know tachy means fast or rapid, and cardia means heart rate or beat, right? So here we go, above the ventricle, fast heart rate. So this is what we would also be known as atrial tach or ATAC. It's kind of the same thing. Now, ventricular tachycardia is exactly the name. Your ventricles are having a fast rhythm. They're beating fast, so it's within the ventricles. Big need to know. Now, let's start off with supraventricular tachycardia. So not only is it above the ventricles, it's your atriums. And your atriums, again, are important for collecting blood when it's returning back to the heart, whether it's from the body or from the lungs. And if you know anything about the blood flow to the heart, then you understand what I'm talking about. And don't worry, we'll have some information about that as well coming soon. So when the atriums are beating very fast, the biggest thing that we are concerned about is that cardiac output. Why? Because the atriums have what we call this kick. That kick is what you see in an EKG, which is your P wave. Okay, so that P wave has what we call an atrial kick. When the blood is filling the ventricles and the blood is leaving the atriums to the ventricles, your atriums do this last little push to get that last little bit of blood, which is what causes a ventricular contraction. However, when your atriums are beating really fast, you lose this atrial kick, thereby losing extra blood. So guess what? When the atriums are beating really fast and they're not properly pushing or giving that atrial kick, which you know you need to have enough force to push. Well, if it's going like this, there's no force being pushed. So guess what? That blood sits there and now you lack the cardiac output you need in order to sufficiently provide blood and oxygen to your body. So they have a reduction in cardiac output. The other thing that you need to know is that it's really not a medical emergency. What we can do is we can manage it through several different ways. Vagal maneuver, so stimulate that PNS, that parasympathetic nervous system, to slow down the heart rate. We can give adenosine, and if you know anything about adenosine, I love this medication because it stops your heart and your heart comes right back. So it literally stops your heart for a few seconds and then resets the heart, okay? And you push it very fast, okay? It's really fun. I've given it like once, and I'm not gonna lie, I had a blast doing that. It didn't work, but that's another story for another time. And then lastly, if they are actually feeling symptomatic and the adenosine didn't work, the vagal maneuver didn't work, we're going to then go into a cardioversion instead. And electrically. Instead of medically treating it with medication, we're going to go ahead and cardiovert them using a defibrillator, okay? There is an option on the defibrillator where you can select to then do a cardioversion, and that can also electrically reset the heart so that it can stop beating so fast. So this is not a medical emergency, and the way to tell the difference between the ventricular tachycardia and the supraventricular tachycardia is that there is a rapid heart rate, but the QRS complexes are narrow. Now, why is that important to know that it's a narrow QRS? Because remember, QRS complexes go along with ventricular contraction. So every time you see a QRS complex, that means that your ventricles are contracting. So if you see a narrow QRS complex, but you see that the heart rate is like 150s, 160s, and you see a P wave, but you see like that rapid heart rate going, and it's regular, okay? Because remember, there's atrial fibrillation, which is completely different. It's not regular. That beat is irregular. But if you see a narrow QRS complex, you can identify a P wave, but it's just rapid. You're looking at SVT, and usually that their heart rate is like in the 200s, like 180s to 200s. I actually had that happen to one of my patients. It was actually pretty interesting. And yes, he survived. So now let's move over to ventricular tachycardia. Now, this is a lethal rhythm. This is a biggie on the NCLEX, and you better know it when you see it, because if you don't treat it, all hell's breaking loose, okay? This is a cardiac arrest. This is a code blue when we talk about ventricular tachycardia. Ventricular tachycardia can have two different types. You can have pulseless tachycardia or ventricular tachycardia with a pulse. Now, the one that I want you to know is that if there is a pulse, then we will do medical treatment or a cardioversion. However, if it's pulseless, you need to defibrillate. You treat it as if it's VFib, because if you don't treat it as VFib, then that patient is dead, okay? You're losing precious time, all right? But if they still have a pulse, that means that the ventricles are still getting some kind of blood out. It's just that it's not sufficient. And if we don't treat it right away, remember I told you life-threatening medical emergency, if we don't treat this right away, the patient is dead and done, okay? Pulseless, however, that patient's already dead. So we treat it like VFib, all right? So they're going to have wide QRS complexes, and you will not see any P wave. Now, why is the QRS complex wide? Because it's happening within the ventricle. The ventricle is not properly pumping. And if you're not pumping, you don't have a pulse, right? So if you don't pump, blood doesn't go out into the body or the lungs to get oxygenated or to give oxygen to the tissues. And now you have tissue death throughout the body. Not good. So again, if it's pulseless, we defibrillate that. We treat that like it's VFib. And if there is a pulse, then we're going to treat it with either antiarrhythmics and or a cardioversion. Again, it can become or convert into VFib. So regardless if you have a pulse or not, you need to act right away. Recap. Narrow QRS complex for supra above the ventricle. So that's the atriums. So it's a form of atrial tachycardia is another way you can kind of say it. All right. And they're going to have a narrow QRS complex. You will see that P wave. The only problem is that you're not getting that extra atrial kick because the heart rate's too fast. It's not relaxing long enough for there to be a sufficient kick to push it into the ventricles. Therefore, you're going to see a reduction in cardiac output. And if you see a reduction in cardiac output, you expect that blood pressure to also become low. Whereas with VTAC, you can have pulse or pulseless. And again, with pulse, we do antiarrhythmics and cardioversions, all right? Because the patient's technically still alive if they have a pulse. That means the ventricles are still able to pump enough, not sufficiently, just enough, because you're still seeing that QRS complex. And again, there is a pulse present. But if you feel for a pulse and they're in VTAC and there's no pulse and they're pulseless, we treat it like VFib, okay? So again, treat pulseless VTAC as VFib, okay? It's equivalent to VFib, so you're going to defibrillate, okay? VFib, defib, pulseless ventricular tachycardia, all right? And again, this can convert into VFib, hence why regardless of what's happening with the patient, you need to act now, All right. So I hope this was helpful. I hope you guys learned a lot. Don't worry, you will see some EKG strips. We're going to get into that soon. But I hope that you guys like, subscribe, and follow for more. Remember, check us out on our website. See you on the next video.